You've got a tachypneic, tired-looking 14-month-old with nasal flaring, subcostal and intercostal retractions, and an O2 sat of only 89% on room air. You're considering putting them on high-flow nasal cannula, but do you properly understand why it works and how to best utilize it in the pediatric patient? I'm Dr. Mina Alesti, Pediatric Emergency Medicine Fellow, and it's time for your Space City Quick Hit of the day. High-flow nasal cannula is more than fancy oxygen. It delivers heated, humidified flow that does 3 powerful things in kids. First, dead space washout. Infants have proportionately larger anatomic dead space. High flow clears CO2 from the nasopharynx, so each breath is more efficient, improving ventilation without increasing tidal volume. Second, flow matching. If the flow you're giving meets or exceeds your patient's inspiratory demand, they pull in less room air and generate less negative pressure. Translation, less work of breathing. Third, low-level positive pressure. Of course not CPAP level, but enough to increase an expiratory lung volume and recruit alveoli. In bronchiolitis in your little ones, it can help stent open small airways and improve VQ matching. Here's how I started. 1 to 2 liters per kilo per minute, then titrate FiO₂ to a SAT goal of 90 to 92. And then, the cardinal rule of emergency medicine, reassess in about 10 to 15 minutes. I'm looking for softer retractions, less nasal flaring, a downtrending respiratory rate, better aeration on exam, and the child should also just look more comfortable. But if I'm still seeing head bobbing, progressive somnolence, rising end-tidal CO2, hypercarbia, diminishing air movement, or apneic pauses, these are red flags. In these situations, high flow can buy you time, but it won't save a child who's headed for respiratory failure. Remember, always reassess your patient, not just the monitor. That's your pediatric quick hit. Now go crush your shift.